So I'm Vinil Shah. I'm one of the neuroradiology faculty at UCSF, and I'm going to talk about how to add value when imaging low back pain. And I'll argue that in the setting of low back pain, you can add value by imaging the pathophysiology of pain, not simply by commenting on age-related degeneration. So we'll talk about briefly the imaging indications for low back pain. We'll talk about common sources of low back and radicular pain. And then briefly I'll touch upon the new lumbar disc nomenclature that came out about a year and a half ago. And I'll talk about finally the majority of my talk on imaging the pathophysiology of low back pain. So the American College of Radiology suggests that patients that have low back pain should undergo imaging if they have an underlying systemic disorder or infection. And that really is a key indicator for getting imaging in the setting of low back pain. And you can see the sagittal T2 image of an MRI of the lumbar spine in a patient with renal cell metastases demonstrates multiple lesions in the vertebral bodies and posterior elements. The American College of Radiology also suggests that patients that have persistent symptoms or cauda equina symptoms or symptoms that haven't responded to conservative therapy or patients that are candidates for intervention, whether it's a fluoroscopic or CT-guided intervention, they should undergo imaging. So let's talk about the two major sources of low back pain and associated radicular pain. So in younger patients, the anterior column tends to be a source of low back pain, and typically it's discogenic pain that causes pain in younger and middle-aged patients. In those patients who have radicular pain, it's commonly due to a disc herniation. In older patients, the pathophysiology of low back pain is a little bit different. For those that have axial low back pain, the posterior column is a more common source of low back pain, and that typically is facet pain, and there can be prominent inflammatory facet syndromes that can cause very severe low back pain. For those that have radicular pain, again, you can get isolated disc herniations, but fixed lesions such as those that cause spinal stenosis are more common in older patients, so patients in their 60s, 70s, and 80s, okay? So let's talk about the basic, let's go back to basics and let's talk about the lumbar discovertebral complex. So this cartoon kind of shows that you have the inner nucleus pulposus and then the outer annulus fibrosus that is anchored into along the vertebral end plates. And when we talk about discogenic pain, it's important to understand how discogenic pain happens, okay? Because we see the sequela of discogenic pain or internal disc disruption on the MRIs that we routinely read. So this concept of internal disc disruption results from an end plate fatigue fracture. And this cartoon that was shared with me by a colleague of mine at the Mayo Clinic, Dr. Moss, it shows that over time, as there's abnormal cyclic loading and cyclic stress that's applied to the end plate, that results in an end plate fatigue fracture. And what that does is that then puts a lot of abnormal stresses on the annulus. And that causes the annulus fibers to separate. And then that precipitates the formation of radial fissures, okay? And it's these radial fissures that are a distinct and unique feature of internal disc disruption or discogenic pain. These are not age-related degenerative changes. These can cause painful low back pain and radicular pain syndrome. So this cartoon here shows that in patients that have the abnormal cyclic stress on the end plates resulting in the fatigue fracture, and then you can see that the annulus can no longer absorb that stress. The annulus fibers separate, and then you have these radial fissures that extend variably to the periphery of the posterior annulus and sometimes all the way to the epidural space. And you can see on MRI that you can see manifestations of these radial fissures as bright T2 signal extending towards the posterior annulus. And we'll talk more about the significance of this in a few slides. Okay, so traditionally, the best, the traditional way of diagnosing in the morphologic changes of internal disc disruption and the associated radial fissures was via discography. And discography is not being used as commonly as it used to be in the past, and there are various reasons for this. Firstly, this is, as those of you that may have performed this procedure, it's not really a very pleasant procedure for the patient. And there are some papers that have come out in the last few years that have shown that accessing the disc, particularly normal discs, can cause accelerated degeneration of those discs. And so many practitioners are not doing discography anymore. When I perform discography, I don't do control levels as much as I used to in the past, because I'm worried that by putting even a small gauge needle into a normal disc, I might be causing accelerated degeneration of that disc. So you can see, however, the value of discography in this adult athlete who had many months of axial low back pain. The MRI shows relatively minor degenerative disc disease at 4-5. But when you look at the corresponding discography images, you can see that all of the discs injected had high-grade radial fissures that extended into the epidural space with leakage of contrast into the epidural space and neural foramen. And so how can we, on MRI, how can we improve our sensitivity for diagnosing discogenic pain? And there are two very important MRI features, and in order to be able to detect them, I suggest that all of you should be doing fat-saturated or STIR imaging as part of your lumbar spine MRIs. One of the features is this concept of a high-intensity zone in the posterior annulus. And you can see this patient who had axial low back pain has a very T2 hyperintense lesion in the posterior annulus. And these can be very painful, particularly when they run close to the traversing nerve roots. They can also cause a radiculitis as a result. And these are really best detected on T2 weighted imaging, and particularly FAT-SAT or STIR imaging. And some people refer to these as annular tears, and as I'll go over in a few minutes, the recent lumbar disc nomenclature that came out over a year ago was a joint effort of several task forces in radiology and spine. And the term annular tear is a term that shouldn't be used according to their recommendations, because a tear implies some sort of a known traumatic etiology, and therefore they don't advise use of that term. So I will use a high intensity zone in my reads, or I'll use the term annular fissure. And when I see this, if this is all I see, I'll put this in the impression, because I know that this is an independent predictor of axial low back pain. Okay, and then one more comment about the annular fissure or high intensity zone. It's not clear whether this represents the radial fissure itself. In many cases it doesn't, but it may indicate an underlying radial fissure, and some people think that this bright T2 signal may represent a vascularized granulation tissue at the site of annular disruption or annular degeneration. So it is an active inflammatory finding and should be mentioned in our impressions. The other finding of internal disc disruption that we can see on MRIs is active end plate marrow edema, again, very nicely seen on the sagittal T2 FAT-SAT image. And I put these, if there is prominent end plate marrow edema at a particular level, I put that in my impression as well, because many studies have shown that end plate marrow edema are also independent predictors of axial low back pain. And these are the so-called type 1 modic changes. Okay, so we've covered the two kind of important MRI markers of inflammation that may indicate underlying internal disc disruption, and that's the annular fissure or high intensity zone and the end plate marrow edema. So let's now move on to from axial low back pain to lumbar radicular pain. And in particular, we'll focus on disc herniations first, then we'll move on to spinal stenosis. So the definition, I'm sorry I created this talk on a Mac, and my word text is getting distorted, but So apologies for that. But lumbar radicular pain is defined as lancinating or electric pain that travels in a narrow band kind of along a dermatomal distribution down the leg. And this is, lumbar radicular pain is different from referred pain from facets, for example. The referred pain, for those of you that are seeing patients and doing spine intervention, you'll know that the referred pain syndromes tend to be more dull pain, whereas true lumbar radicular pain travels along a narrow band and is sharp or electric-like. And why is it that why is it that epidural steroid injections work in these patients? It's because it's not just because neural tissue is getting compressed by disc herniations. It's because in order for there to be pain, many experimental studies have shown that you need to have not only neural compression or neural contact with the disc herniation, but you also need to have an inflammatory reaction. And therefore, epidural steroid injections, which are anti-inflammatories, they tend to work in settings of acute or subacute disc herniations. So let's talk briefly, before we move on to disc herniations, let's just review lumbar disc nomenclature. And as I alluded to before earlier in my talk, the 2.0 version was published in the Spine Journal a little under 2 years ago, and this is a free document available online. And I encourage you guys who are reading lumbar spine MRIs to read this. And the goal of this was a combined task force of the ASSR, ASNR, and the North American Spine Society. And the goal is universal standardization of language. And I think by using uniform nomenclature in our reports, I think we're all going to be more consistent to our referring physicians and surgeons. So basically, this is, again, going back to basics. You can divide a disc into 4 quadrants or 90 degrees each, and if you have local displacement of disc material beyond the confines of the margins of the disc by less than 25% of the circumference of the disc, then it's a disc herniation. And this is one of the differences in the new nomenclature. So previously in version 1.0, if there was focal displacement of disc material for less than 25%, that was called a focal disc herniation, either a protrusion or an extrusion. And if disc material in that nomenclature extended by 25 to 50% of the circumference of the disc, then it was called a broad-based herniation or broad-based protrusion, and that term is no longer used. So now we're only going to be talking about herniations that are either protrusions or extrusions, or we're going to be talking about bulging discs, okay? And so if you have disc material that extends circumferentially, kind of symmetrically around the margins of the perimeter of the disc, then it's a bulging, symmetric bulging disc. If you have disc material that extends more than 25% of the margins of the disc and it's asymmetric, then it's an asymmetric bulging disc. So those are the only terms we're going to use. And then if in any one plane, if a focal disc herniation has the neck of the disc is